both. And then and after the EEG came into the picture, people were looking into more into the relationship between night and seizures, and understanding of sleep actually came into the picture. As some of you guys might be aware that there are different stages of our sleep. Some of our sleep is light in nature, some of it is really deep in nature, and certain stages of the sleep are more likely to have seizures as compared to the other. Like I said, the nighttime seizures tends to occur in the first 2 hours of going to bed. This is when we are what we call as stage 2 or stage 3 sleep, which is kind of deep sleep. And there are certain characteristics in those sleep when the excitability of the brain is much more prominent, and it makes the person who is predisposed to having a seizure more likely to have seizures during that period. And if some of you guys know about the dream sleep, which is called stage REM sleep, which is a sleep in which the brain is not as excitable and it does not fire at the same time. So seizures are less likely to occur out of stage REM sleep or the dream sleep as compared to the other stages of the sleep. So there is a strong relationship between stages of the sleep and seizures, and also more likely some seizures have predisposition to occur during your sleep-wake cycle.
Okay, great. So nocturnal seizures can obviously be difficult to recognize. What are some of the other conditions in childhood and adulthood that can be confused with nocturnal seizures? And how do neurologists, patients, and families accurately detect and diagnose nocturnal seizures?
So I can take that one.
Okay.
So this is a question that comes to pediatric neurologists all the time. It's a common thing we see in clinic where children do funny things in sleep. Are they seizures? Are they not seizures? And the one thing I like to say is not all that shakes is a seizure. There are lots and lots of things that happen in sleep that look scary, that look bizarre, that sound awful, but they're not seizures. So there's a term, and Dr. Kaplish does this more than I do in the world of sleep medicine, but the term that we use for unusual behaviors related to sleep or around sleep are what we call parasomnias. That's a very, very common condition in children that can mimic seizures. So all of you must have heard of night terrors. And they can be really hard to tell what on earth is this kid doing. The child's eyes are open, screaming just after going to bed. You know, everything that we ask you about a seizure is happening in that night terror. Is your child aware of aware of his or her surroundings? No. Are eyes open or eyes closed? We say eyes are open. You know, can you get your child to respond? No. So they can be really hard, but a good history, sometimes actually videotaping what you see. And for, you know, some people in the audience who I do recognize, this is something that I talk a lot about in my clinic, that, you know, videotape what you see. 5 years ago, 10 years ago, when, you know, smartphones weren't as smart as they are today and not everybody had one, it was kind of a to-do to do that. But I think most of the parents I see in my clinic have phones that are smarter than the phone that I have and can definitely videotape things at the drop of a hat. You know, many places now have technology where you can upload your child's video directly into your doctor, so you don't even have to go and show it to your doctor and make time. So parasomnias is one thing. There's another entity called sleep myoclonus or hypnic jerks, and these are just little jerks that all of us experience in a boring lecture, hopefully not today, when, you know, you're dozing off and you suddenly wake up. Babies do that a lot. And again, I cannot tell you how many times we see this. You know, it's great. I love it when I can reassure somebody this is not a seizure, and this is one of these seizure mimics. There are behavioral episodes which happen during the day, such as breath holding spells. Those typically don't happen at night. I'll let my colleagues here talk about some of the adult sort of counterparts of this, but just things like, you know, bear in mind common things like sleepwalking, sleep talking, just myoclonic jerking in sleep are probably some of the common things we see that are mimics of seizures, particularly in kids in sleep. getting a good story from you guys, from the parents, from the patients themselves, knowing what time in sleep they happen. Is it, like Dr. Kaplish said, REM sleep, non-REM sleep, sometimes looking at a video. And, we sometimes will even bring in kids for either a sleep study or EEG monitoring, and we'll get into that a little bit later to try and differentiate some of these. Dr. Beimer, anything in the adult world that's different?
Yeah, so a lot of the things in pediatric patients apply to adults as well, but there's a few things that can be sort of confused for seizures at nighttime in adults that don't happen quite as commonly in children. One is a different type of event that we categorize as a REM behavior disorder. So we talked about, Dr. Kaplish, about REM sleep and non-REM sleep. So REM sleep is dream sleep, where you have your dreams. And in a patient normally, in a person normally at nighttime during REM sleep, dream sleep, your body doesn't move. But in certain cases, there are disorders in which you can act out your dreams at nighttime, and that happens during the REM or the dream stages of sleep. And that is a similar thing that can be, anything from thrashing movements to kicking, other behaviors that look concerning, of course, but are difficult, of course, just on the appearance outward to tell from seizure, for example. So using smartphones, using technology to try to record the events, there are certain features that you can use to try to distinguish one from another, but oftentimes the best thing that we have, the best technology, is the use of video plus EEG to record those types of events at the same time and see if we can find anything that suggests it's a seizure apart from the way that the behavior looks. Otherwise, a lot of the same things that affect pediatric populations affect adults as well, just in different frequencies.
Did
you have
anything
anything
you
to
wanted to
add?
add?
So we talked about the dream sleep. So what are the things that would be helpful for a clinician? And many times when you guys see these patients having episodes in the night, is the dream sleep tends to occur in the second half of the night. So more so in the early hours of the morning. And like Dr. Here mentioned that the dream sleep the REM sleep behavior disorder tends to occur in the 3, 4, or 5 in the morning. And the usually seizures that occur in the night are more briefer in duration as compared to people that have parasomnias or any kind of other behaviors. Like sometimes sleep terrors can be very long, so they can be about 20 minutes or longer when the kid continues to cry. So the duration, the time of occurrence in the night, the behaviors, and typically seizures when they occur in the night as compared to the other behaviors that occur in the night, they are very stereotypical, meaning that what happens to the patient is very much consistent or very similar to episode to episode to episode. So again, kind of getting some information on what happens to the patient is really very helpful to the clinician to make a judgment, because it is critical for us to make kind of a assessment on, because the treatment is really different on the two circumstances.
Okay. Can you talk about the primary differences between overnight video EEG monitoring and doing a sleep study, and under what circumstances you might want to do one over the other, or when would you do both? And is there even a hybrid version of those tests that you can do? How do you make that determination?
Do you want me to do the kids first?
Yeah, sure.
Okay. So actually, this is a great question, because when we talk about overnight EEGs, it means the child or the patient spends the night in the hospital and so sleeps in the hospital. And it is very easy to call it a sleep EEG or a sleep study and get the two confused. So primarily when we talk about an overnight EEG, or in some places it is called a long-term monitoring EEG study, this involves mainly placement of a whole array of EEG leads on the head. In order to keep them secure, often the EEG technologist will put a head wrap on so that you don't yank them out in the middle of the night. There are some other monitors that go on, but they are mainly monitors that just monitor the heart rate during sleep. And for a long-term EEG monitoring study, that's kind of the mainstay of what we record. We're really interested in recording what the brain waves look like, during the daytime, during drowsiness, during sleep, and if we're looking for specific events, there's a video camera on as well, what the events look like. Now, a sleep study primarily focuses on physiology of sleep. There is some EEG in there that you need to identify the different stages of sleep, but the question that you're asking is a little different. There is a lot more physiological monitoring, like breathing and oxygen with how the chest wall moves, and Dr. Kaplish can tell you more about that. Now, there are versions where you can do a little more EEG with a sleep study, but the reverse can be a little tricky. Now, a lot of these studies are best done, particularly the sleep studies are best done in a sleep lab. Some of the overnight longer EEGs, we can do them in a take-home model, what we call an ambulatory EEG. Whether you can do video with the take-home EEGs or not depends on what technology, software you use. And so there's some variability over there. But I think the main thing to sort of recognize is the question that is being asked and therefore what study one orders. Now, Russ asked whether we get one or the other or both, and I think the only way to answer that question is it depends on what you're looking for. Dr. Kaplish, any more about the difference in?
Yeah, I think I agree with what Dr. Joshi has just mentioned. So the sleep study does involve more robust recordings, but the channels of the EEG that we record are more minimal. As in an EEG, we do 18 channels or 18 channels EEG recordings, as compared to in a sleep study, we are basically doing maybe 4 or 6 channels in a simple regular sleep study. But we do monitor. If some of you guys have had a sleep study, you might recall that we put airflow sensors on your nose and your mouth when we can measure your airflow when you're going in and out. We also put elastic belts on your chest and your belly so we can monitor your thoracic and abdominal movements. We put a pulse ox on your finger to measure your oxygen. We put limb leads as well, so when people are moving their legs and the arms, we can also record those. But in a typical sleep study, we don't put electrodes in the temporal region, which are the major areas of where epilepsy tends to occur out of. So there is a big limitation to a regular polysomnogram as compared to the video EEG monitoring. And also the other thing that I would mention is that typically long-term monitoring has the potential to record data over many days. Polysomnogram are typically done over just a single night period, and it's very likely that one may or may not have their episode in the single night. So the question comes is, when should we do a polysomnogram as compared to a video EEG monitoring? Then there is a hybrid model. In sleep studies in our center, we tend to do expanded EEG recordings. We are able to do much more different recordings as compared to a regular polysomnogram. But again, it is just done over a 1 or a 2 day window period, trying to capture the episodes. So those are the big differences. When should we do a sleep study as compared to a video polysomnogram? For example, when it is not clear when the diagnosis, whether this is a nighttime behavior, is a parasomnia or a real seizure. So that would be something that potentially would be helpful. The second thing that I would say is that many patients who have bad epilepsy, they also commonly have disturbance with their breathing while they sleep in the night. It has been estimated about 2/3 of the patients with bad epilepsy have sleep apnea. So those can be underlying factor that potentially can worsen somebody's underlying disease process. So if you have somebody who has potentially snores or is sleepy during the daytime, and also has a body habitus or is obese in category, or the back of the throat does look very tight, their neck circumference is like say 15 or 17 inches, those are patients that potentially, and many of the older medications that we use for seizure control have a side effect of weight gain. So keeping those in mind will help you a clinician to make a determination and listen whether I should also look for other factors that might be affecting this patient with an epilepsy. Nick, do you have anything else?
Excellent. Nothing to add.
So I was going to add just one more thing. Another device that is used for treating epilepsy is the vagus nerve stimulator. And there is some reason to believe that individuals who are, I won't say that this is standard of practice, this is a little more kind of emerging stuff, is just keeping the whole sleep apnea aspect in mind in the setting of vagus nerve stimulation. Having sleep apnea doesn't mean a patient who needs a vagus nerve stimulator can't get one, but it's just an extra thing to put in the evaluation.
Okay, great. So with some types of epilepsies, seizures are primarily or exclusively nocturnal. Can you talk about some of the different epilepsy syndromes and types of epilepsy that feature exclusively or primarily nocturnal seizures?
So for adults, the one that we encounter most often is in frontal lobe epilepsies. So the location of the seizure comes from the front part of the brain. And in patients with nocturnal epilepsy, as many as a quarter of them have a family member that has had epilepsy too. And so there's a specific type of frontal lobe epilepsy that's genetically inherited. It's called autosomal dominant frontal lobe epilepsy. And in those conditions, in that particular disease, it's a dominant inheritance, which means that each of us gets a set of chromosomes from our parents. And so if one of our parents has that genetic change, then you have a 50-50 chance of inheriting that same genetic change. And so that's why a higher number of patients with frontal lobe epilepsy in sleep at nighttime have a more likely chance of having a family member than other epilepsy syndromes. And temporal lobe epilepsy as well, so I'm talking about different locations of where the seizures come from in the brain, also has a tendency to sometimes have more frequent convulsive seizures when they happen at nighttime. And so those are one of the two both the two major adult epilepsy syndromes that I think about. Do you want to talk about the pediatric ones?
Sure. So in the pediatric population, we do see frontal lobe seizures happening at night. We do see the temporal lobe seizures happening at night. There are a couple of unique epilepsies or epilepsies that are unique to children where seizures tend to happen at night. A very common epilepsy is something called benign Rolandic epilepsy. The other term for this is benign epilepsy of childhood with centrotemporal spikes. It's a bit of a mouthful. But these are school-age children who have a handful, usually a small number of seizures shortly after going to bed. And they can be focal seizures or they can be focal seizures which very quickly become convulsive seizures. Their EEGs have a very characteristic pattern, and actually if we diagnose these kids with this type of epilepsy, we like to be very careful when we diagnose this type of epilepsy because the outcome tends to be very good. Another type of epilepsy with predominantly nocturnal seizures is an epilepsy where the origin of the seizures is in the occipital region in the back, and it goes by the name of the neurologist or clinical neurophysiologist who described it. It goes by the name Paniatopoulos syndrome, again, kind of a long name. But these are seizures that usually happen shortly upon falling asleep. They're very peculiar in that they have a lot of, gagging and funny behaviors and vomiting that happen. They can be really, really long, the seizures when they happen. But again, this is a type of epilepsy that tends to have a good outcome. Some of the more, there are some other types of epilepsies. There's a type of, it's kind of a broad epilepsy syndrome called Lennox-Gastaut syndrome, where seizures with a very prominent tonic or stiffening component can happen in the middle of the night. And then another epilepsy called juvenile myoclonic epilepsy tends to have seizures not so much in sleep but shortly upon awakening. So there's probably some relation to the sleep-wake transition. So even though it's not strictly a nocturnal epilepsy, but those seizures tend to happen in the early hours of the morning after waking up.
Okay. And can you talk also briefly about epilepsy with continuous spikes?
Sure. So another entity which we encountered in pediatrics is this electrographic picture of continuous spike waves in sleep. And it's exactly what I said. So when the EEG is recorded in the awake state, you see few, not so many, sometimes hardly any spikes. But as the child transitions into sleep, there is this sudden, what we call activation, or there's just like spikes all the time. There are criteria that are used to sort of define whether this meets criteria for continuous spike waves in sleep or not. And this is sort of becoming an entity that is getting a lot more attention in the epilepsy world. There's a very classic syndrome described with this EEG picture that is related to some language dysfunction. But I think as we understand more about brainwaves and sleep. I think we're seeing this a lot more kind of in a much broader scope. In fact, the epilepsy that I just talked about, benign Rolandic epilepsy, can have a very similar picture, but again, you have to go by the company that it keeps and not just use one criterion to diagnose it. Now, identifying continuous spike wave in sleep can be important because there are specific treatments that are tried for this particular EEG picture. But yes, we do see it, and that's a diagnosis that we usually make based on EEG. It's not something that has clear clinical or easy to identify clinical symptoms in order to make that diagnosis clinically.
And for types of epilepsy not known for having primarily nocturnal seizures, how common are nocturnal seizures?
Question.
So there's reports dating back to all the way 19th and 20th centuries. I didn't know the answer to this question before I looked it up, but apparently up to 20% of patients with epilepsy have almost exclusively nocturnal seizures that happen at nighttime. And that sounds like a high number. Sounds like a high number to me, actually, because it seems to me like when I see patients in clinic, I don't think I actually hear from them that up to 1 out of every 5 has mostly seizures at nighttime, which I think speaks to how difficult this can be, because sometimes it's hard to know when things are happening at night. No one is awake to see them happen. If the patient doesn't share a bed partner, there's no one around to see it happen, and the person themselves may not be aware that it's happening. But when we look at people that have epilepsy in more detail, it's actually been shown that there's a higher rate of it than I think maybe is obvious to us when we think about it. The other thing too is that some patients, though they have epilepsy that have seizures occur almost exclusively at nighttime. When people have looked at this, scientists have done studies, they've defined nocturnal epilepsy as being mainly 90% or greater of their seizures happen at nighttime. But that still means that they have 10% or so that could happen during the daytime. So there's some ambiguity there. Sometimes it's hard to define specifically when someone is having nocturnal epilepsy versus epilepsy that has some seizures that happen during daytime, some at nighttime.
And on the converse, how many, for people who don't typically have one of those syndromes that's associated with exclusively nocturnal seizures, is it fairly rare for people to have a nocturnal seizure? Is it relatively common? I guess that's what I'm trying to figure out.
I would say it's actually relatively common.
Okay.
I mean, there are some patients that have, again, only seizures that happen during the daytime,
Yeah.
but I personally feel like I've seen many in which they say most of my seizures happen during the day, but then also I've had them in the early morning,
Right.
as I'm getting up in the morning or just after I go to bed. And so not everyone fits into a nice box of one versus the other.
Right. Go ahead.
So, I think I would agree with what Nick has just mentioned. I think sleep deprivation is one common factor in many of the patients who also have daytime seizures, or predominantly daytime seizures, because as if you have had sleep deprivation for example, not sleeping enough for 2 or 3 days at a stretch, that you are likely to have a certain stage of sleep when you're on your recovery day, when you actually are sleeping. So you're more likely to have a robust kind of a non-REM sleep or more deep sleep, so you're more likely to have a seizure, and that's what we see clinically as well, and that's what we talk to patients about. Hey, sleep deprivation is a factor, and that even if you're having daytime seizures, then potentially it could be that you have a seizure in your sleep period.
Okay.
I think that's a good point. Some of the patients I take care of are adolescents, and the lifestyle of an adolescent is inherently built around sleep deprivation. No matter I sit in clinic and tell patients, I tell high school kids that they need to get so much sleep and they need to, not stay up late at night, and that, it's all very well to say that, but it's hard to do. So I think it is important to recognize that sleep deprivation can be a factor, and to at least try within limits of, not completely derailing a teenager's high school life, but, within some limits to like recognize that sleep deprivation is a problem for provoking seizures in susceptible individuals. So I think that is a very good point to recognize that it's not just necessarily the nocturnal sleep stuff, but even sleep deprivation that can be a provocation for seizures.
Okay. And, okay. Among nocturnal seizures, can it be any seizure type experienced nocturnally, or are there certain types that are more common?
So I think, again, Dr. Beimer and I were discussing exactly this before we walked in. More likely than not, it's focal seizures that happen at night. We talk about frontal lobe seizures, we talk about temporal lobe seizures. The convulsive seizures in juvenile myoclonic epilepsy usually are more likely to happen in the early hours of the morning shortly upon awakening. Does that mean that one can never have a convulsive seizure in sleep? That's clearly not the case. But again, if you had to sort of see which are the ones that are more likely, I think it's the focal ones that are more likely.
Yeah, and to clarify focal. So when we say focal, we usually mean to say that the seizure starts in one very specific part of the brain. And when we talk about focal seizures, we're talking about where they start in the brain, but we're not necessarily talking about what they look like outside. So focal seizures, what they look like to you if you're watching it happen, could be anything from a person just opening their eyes briefly, looking like they become awake, and then close their eyes again. It could be as subtle as that. And then another type of focal seizure that could happen at nighttime could be someone waking up or appearing to wake up, their eyes open, and then they let out a yell or a cry, and then maybe they kick their legs or make a bicycle type movement, something like that. That's also a focal seizure. And so there's a broad range of the different types. When we talk about convulsive seizures, we're usually talking about whole body shaking, stiffening, that sort of thing. And so focal seizures can turn into convulsive seizures, or they can just remain as focal seizures, meaning they just have that one component first.
And one thing I would mention is that the frontal lobe seizures can be somewhat deceptive in the sense that often there is no alteration of consciousness. Sometimes people, after a seizure, they are kind of more drowsy and are out of it. But frontal lobe seizures during the night may actually have no episodes of confusion, or time to get back to normal is really very minimal. And some people even respond during their seizures appropriately. So it is sometimes a diagnostic challenge at that point, whether in these circumstances.
Right. So daytime seizures are a challenge because of the possibility, because of the disruption they cause in your routine, because of the injuries, the potential for falls, and the impaired consciousness. But nocturnal seizures may not seem as dangerous or disruptive because you're laying down in a nice soft bed. You may go right back to sleep after the seizure. So people may think that, well, maybe nocturnal seizure is not all that important to track or be aware of. Is that accurate, or should people be as concerned about nocturnal seizures as they are about daytime seizures?
I think in general, having uncontrolled seizures, whether they're daytime or nocturnal, one should be concerned. Nocturnal seizures, especially exclusively nocturnal seizures, can be a little tricky just because, what kind of vigilance do you need? Can be, it's a hard sort of area to navigate. Now, some individuals who do have a lot of nocturnal seizures may be tired in the morning. And there can be some disruption of daytime just activities, and for children it can be disruption of school if kids have a seizure very shortly before waking up and they are postictal and they are tired in the morning, they may end up missing school. So I think there are implications of nocturnal seizures. This is another thing that's a very practical issue, is those who have nocturnal seizures or predominantly nocturnal seizures sometimes take higher doses of medicines at night. night, and is there a carryover effect of sedating effects of those medicines in the daytime? So I think, sure, nocturnal seizures happen sort of in more private settings because they're not happening, out at school or in public, but I think there are implications of nocturnal seizures also.
I agree with Dr. Joshi has just mentioned, and I think when we do sleep studies in these patients, we often find, and research has shown that their sleep is getting quite disrupted when we analyze their EEG. So these patients tend to have more briefer arousals and sometimes prolonged arousals, and this has been described in also in temporal lobe seizures as well as in generalized epilepsy. So they tend to spend a lot more time in lighter stages of the sleep. They don't tend to go into deeper stages of the sleep. They also sometimes also have less dream sleep. And all stages of the sleep, some tends to have more bodily function, whether it is consolidation of the memory, how refreshed you feel when you wake up in the morning. So those, I think, even if you are not at a risk of a bodily harm because you're sleeping in a soft bed, doesn't mean that cannot have consequences. I think I agree with that completely, and the research has shown kind of more so consistent results.
Okay. So having said that, how vigilant should patients and family members be in tracking or looking for signs of nocturnal seizures? Particularly if you're newly diagnosed and you're not, you might be tempted to spend your whole day hovering over your family member's bed and make sure they're not having a seizure. So how do you know what an appropriate amount of vigilance is?
I think that's hard to know. I mean, from one standpoint, you have to make sure that family and caregivers for people living with epilepsy have to take care of themselves too, right? And so although it's important to know if people are having seizures when they're sleeping, the best thing, if that's obvious, is to, of course, keep a log, keep track on a daily basis. Yes, I saw in the nighttime that you had this happen, and keep a good record of that so you can share it with your doctor the next time you see them. But it also makes it difficult because I don't think anyone expects that you stay awake all night and watch your loved one sleep, right? That doesn't make any sense. So if the person doesn't have a bed partner, if they don't have someone that stays in the room with them, I think it's hard to ask or expect anyone reasonably that they would be able to track that on a regular basis. But if you do share that bedroom or the bed with that person, then it would be helpful just to know when you do wake up next to the person with having a seizure, what's happening to them. And that's, of course, why we have the technology that we have. If there's a suspicion that they're still having seizures, if you've been treated, but you're wondering, I wonder if they're still having seizures, I obviously can't stay awake all night and watch them, then that's when we would do an EEG with video. We would do a sleep study, or we would do an inpatient hospital stay, or we would do that at-home EEG recording, perhaps with a video, and see if we see evidence that they're still having seizures. Let the technology work for you, I think would be good.
I couldn't agree more. It's, we get asked this all the time. It's a very difficult question to answer. Should parents sleep in the same room as their children? Should parents sleep in the same bed as their children? I think my child is having seizures at night. I am not sleeping because I don't know what to do. I wish there was here is the formula or the recipe to, of how vigilant one should be. I think we have to do this on kind of a case-by-case basis and individualize our recommendations for families. I think knowing what kind of epilepsy a child has, keeping some sort of track or log to get sort of a sense of the pattern. If there are unusual events at night, talking to your doctor about them. Where necessary, again, let technology be your friend over here. And at the same time, balancing the vigilance with everything else. So there isn't here is how vigilant one should be, but I think it needs to be on a case-by-case individual basis based on what a child's history is, what particular epilepsy you're dealing with.
Right. Okay, and you, Dr. Joshi, you touched briefly on this, but if a patient has nocturnal seizures, are there unique approaches to treatment in terms of are particular treatment options more effective or dosing?
Sure. So again, it's not a one-size-fits-all kind of answer, but it's something that clinicians, families who work together should take into consideration. There are some medications that we use with a little more heavier dosing at night. Sometimes in a certain situation, doctors may choose to treat at night only. There are certain medications which you might add on just at night. So I think in terms of how to approach either exclusively nocturnal or predominantly nocturnal seizures is going to depend on an individual case. One thing that Dr. Beimer mentioned, which tends to be not uncommon, is even in those individuals who predominantly have seizures at nighttime, tend to have some seizures during the day. So most patients with even predominantly nocturnal seizures end up on medications that cover them 24/7. Also, just the pharmacology, the way the medications work, it's a little tricky to just give a dose every night. And we don't want swinging blood levels off medications with nothing in the day, and then sort of your body's playing catch up every night. So again, I think the answer is the same. You kind of individualize treatment. You talk to your doctor and work together.
Great. Are there any behavioral approaches to reducing the frequency or the severity of nocturnal seizures? In terms of, you mentioned, getting regular sleep. Is there anything beyond that can be done?
Yeah, I think sleep deprivation is something that I stress with my patients, whether they have seizures or parasomnias in the night. The second thing I think I always question them about is how can I improve the arousals in the night, because it's been thought that arousals in the night can actually, once they wake up, whatever the trigger is for the waking them up, might actually predispose them to have a seizure, because the brain is very excitable, especially in the night. So I think I always ask symptoms about sleep apnea, and if there is even a subtle symptoms that are suggestive for sleep apnea, I tend to kind of be aggressive about treating it or evaluating that. And I have found that is clinically in my patient group is very fruitful, that if they have sleep apnea or any kind of a sleep dysfunction, that I can minimize their arousal patterns and improve their quality of sleep. It has been very beneficial in my patient population.
Okay, great. So one of the biggest concerns associated with nocturnal seizures is SUDEP, or sudden unexpected death in epilepsy. There may be also concerns about aspiration or suffocation or even undetected status epilepticus. Can you talk more about how nocturnal seizures influence the risk for SUDEP and other serious complications?
So this is a difficult question. It's always on many people's minds because that's one of the most frightening things that could potentially happen from or related to a seizure is death, of course. And with nocturnal seizures, there's been some suggestion looking at the incidence or association of SUDEP with nocturnal epilepsy. And they noted that in some patients, this is a study done some years ago, that there was a certain frequency of sudden unexplained death that happened during nocturnal seizures, for example, or during the nighttime. Most patients are often found in bed. The assumption is that you would assume that sleep then increases your risk. I don't know that that's necessarily the right assumption, but that's the worry, of course. We know that there's this rate that patients have a risk of having sudden unexplained death in epilepsy over time. The rate is actually very small. So if you look at it in numbers, over 1,000 patient years, meaning that if you take a person in this room that has epilepsy for 20 years, that's 20 years of patient years with epilepsy. When they look at 1,000 patient years, there's usually less than one person has unexplained death, sudden unexplained death from epilepsy in that context. So the numbers are actually very small. And in a more recent study, there was a group in Italy who looked at patients with nocturnal epilepsy, had most of their seizures during the nighttime, and they tried to see if that risk of SUDEP was higher in that group of patients than it is in every patient that has epilepsy, and they found the answer was no. And so there's conflicting results about whether or not perhaps there's an increased risk with nocturnal seizures, but nonetheless, the things that we know are that taking the medications at the right times, not missing doses, doing all of the things that you can do to prevent any seizure from happening is something that can potentially influence how likely it is that that could happen in nocturnal epilepsy.
Okay.
So things are a little different in the pediatric population. I think what we see in terms of the other coexisting conditions in children with epilepsy can be quite different from adults with epilepsy. And when, again, studies that have looked at what are the risk factors for deaths related to sort of epilepsy in general, there are several other factors, usually related to the underlying condition, that influence mortality in epilepsy. Now, that doesn't mean to say that sudden unexpected death in epilepsy does not occur in children, but the incidence is even lower in children. One of the risk factors is poorly controlled epilepsy, and I think that underscores the point of, counseling families, counseling our patients. And I think it's important, particularly in the adolescent patients where the risk rises a little bit more than the much younger kids, to be compliant with medications. One thing we can work on is keeping seizures under control. And so, again, so there are some factors there. There's a lot of work that is being done in this area to try and understand, is it preventable? Can we understand the underlying mechanisms? There are certain, patterns on EEG that people have talked about. There are, changes in heart rate with seizures that are being looked at. So it's a real risk, but I think it's a very frightening thing to think about. But I think what one should recognize is, and again, doctors should probably be talking more about this with their patients also, is what the real numbers are.
Okay. I've got 15 minutes left, so I want to make sure we have some time for Q&A. So I'll just ask this one last question, which is, given the risk of SUDEP, many patients and family members want a way that they can be alerted to a nocturnal seizure. Can you talk about the potential benefits and limitations of some of the different options out there?
So, there are a lot of, be it devices, seizure dogs, special pillows that are out there that, with the idea of potentially reducing the risk of SUDEP. I think none of these have sort of gone through rigorous clinical trials. Which is their biggest limitation. It doesn't mean that might not be the case. I think if we did this maybe 10 years from now, we may say something very different. But I think if again, one has to balance how much disruption just sitting up at night and watching a loved one with epilepsy versus integrating more normalcy into life. It's a difficult balance, but I think it's important that we strike that for a number of reasons. If it is something as simple as a video monitor that alerts a family member in a different room to a seizure happening. I know that seizure response dogs are useful and popular and loved for a variety of reasons. What the data are in terms of reducing the risk of SUDEP is very hard to comment on, because I don't think we know that. And so there are and again, I think it's important to individualize this and speak with your doctor about whether some sort of seizure alerting system may be appropriate for a given patient.
Okay, great. Well, I think we are going to open it up for questions, but I want to thank you for covering this topic so well. And before we even take questions, does anyone in the audience have any strategies or tools that you've successfully used to manage nocturnal seizures? And then we'll open up for questions. Okay, Angie? Wait.
Hold on, I got a
for the
microphone for you.
There you go.
We use the MFit monitor, which fortunately hasn't been ever alarmed, other than a false alarm a couple times. But it gives us an additional secure peace of mind. Also, our daughter's young enough that she still sleeps with a video monitor on. And luckily, if we wouldn't have had that on for her first tonic-clonic seizure in the middle of the night, I don't know where we would be at this point. So if you do have young children, that might be a good thing to have a video monitor and potentially also use the MFIT monitor. That has given us additional peace of mind to help us get back to sleep a little bit.
Great, and that's a mattress-based monitor, right? It goes under the mattress and it senses movements. Okay. Anyone else use anything that's been effective in the back?
Does the mortality rate go down with nocturnal seizures, or depending what kind of seizures you have, I guess?
Can you repeat? I'm sorry.
The mortality rate of seizures, is there certain lives, years taken off if you have a nocturnal seizure?
Does the risk of death is it higher with nocturnal seizures? I don't know that that's necessarily true, no. I don't know of any evidence that suggests that the risk of death is higher with nocturnal seizures specifically.
Up front?
Hold on. Everybody just raise your hand and we'll try to get to you. And
Yep.
We'll try to get to as many people as we can, so please keep the questions short.
Can you talk a little bit about memory loss, specifically short-term memory loss in nocturnal epilepsy?
Go ahead.
So I guess the thing that I immediately thought of when you asked that question is probably Dr. Kaplish's expertise with sleep, and memory loss and trouble with memory and concentration certainly tied to how good your quality of sleep is at night. And if you are having nocturnal seizures that you may not even be aware of, it may disrupt that regular sleep pattern and reduce the quality of your sleep overnight. We've all had the experience of not getting very good sleep, and you can imagine, if you have that happen every night, even if you're not aware of it, how that affects your ability to think and concentrate over the long period of time. So I think that the answer is yes. If you have nocturnal seizures that are not treated well enough and they happen often, it can really disrupt sleep over the long period of time. I don't know if you have other things to add.
So I think the memory functions lies more so in the temporal lobes and nests in there. And I think if you have nocturnal seizures and they are kind of more focal and arising out of the temporal lobes, you probably have more higher risk for having memory issues. And especially, I think, if you think of the seizures, it's mostly what we're talking about is happening as a clinical seizure. Now, most patients with epilepsy will have kind of discharges here and there all night long during their sleep. That doesn't mean that is necessarily, there's no evidence suggests that is actually harmful. It's mostly the more prolonged clinical seizures. I would potentially think about that temporal lobe epilepsy, which may occur in sleep, it's less common as compared to frontal lobe seizures, is more likely to have trouble with memory as compared to others.
Question?
We've read that the long-term prognosis for specifically pediatric patients with continuous spike wave in sleep or ESCS patterns is not very good. It's very serious syndromes. What does the latest data and research show for long-term prognosis?
So I can tell you one thing. It is a very it's a topic that has generated a lot of interest in the pediatric epilepsy world. We tend to be fairly aggressive in recommending treatment for ESES. And ESES, just to sort of put it out there, stands for, we call it ESES. Another term that is used synonymously with it is what I just mentioned, the continuous spike wave in sleep. And this is, like I said, this is exactly what it sounds like. Is it looks like there's a big long seizure happening in sleep because there are continuous spikes in sleep. In terms of, one concern we have, I don't know that there are any what we call, here is the before, here is the treatment, and here is the after type of study, what we call a prospective study, so looking ahead. But one of the concerns we have is whether untreated ESES has an impact on learning, whether it has an impact on memory. Again, one has to balance. Some of the treatments that we recommend for these patterns themselves have impact on learning and memory, so one has to balance those. But absolutely, it is, it's part of the reason why treating ESES has become a more standard recommendation than maybe it was 10, 15 years ago. There are sort of ongoing studies. There is ongoing lot of examination and scrutiny of this process, and I think this is such an area of interest and examination in the scientific world, in the neurology world, that the exact same panel discussion maybe 5, 6, 10 years from now might be very different.
Another question?
Can you comment on sleep aids that you would take maybe for nocturnal seizures? And you would take your seizure medication, of course, but it seems that there's that waking or incomplete sleep cycle. Would sleep aids help at all in any of reducing seizures?
I don't think there is any data to kind of support that. Now, in the older age, before any anti-epileptic medications were around, one of the medication that worked both was Klonopin that was being used. But I think more and more we are learning about the use of the sleep aids, not necessarily in epilepsy or any in general. I think we are more and more learning that use of the long-term medications for sleep aid, such as Klonopin or other sleep medications, may not be good in the long run in general population. For example, especially in adult age group, use of the sleep medications are increasing the increased risk for falls. And we are also noticing that, especially in women, the sleep aids, even if they are used at a reasonable doses, can result in kind of more drowsy, especially in women. So, for example, the more commonly prescribed medication, which is Ambien as a sleep aid in general in the community, only 5 milligrams is what is FDA recommends as compared to 10 milligrams for women. So it's more of the half doses. So I think we are all leery in sleep medicine when we have to use sleep medications in general, because there are other treatments actually that work very well. They have not necessarily been studied in the epilepsy patients, but I think there is data to suggest that the use of the medications which are specifically for epilepsy may actually improve your sleep in general, by improving your arousals, by improving your sleep continuity. And there is a big literature on how anti-epileptic medications for seizure medications actually affect your sleep. Some of the medication actually improve your sleep more as compared to the others.
Yep.
I know you've touched on this slightly before, but you said you're more prone to have seizures just entering sleep and then just exiting in the early morning. Where does the opposite, lack of sleep, fall on that scale versus deep sleep, just going into, and then just extreme lack of sleep? How does that?
I think I would answer this question, and I hope I get you the answer. Is that there are different seizure types that are more likely susceptible to sleep deprivation. Like Dr. Joshi has mentioned, that juvenile myoclonic epilepsy, which tends to occur more so in the early hours of the morning, especially when you wake up or soon after you wake up, you're more likely to have susceptible to epilepsies that are generalized epilepsy be susceptible to sleep deprivations. That would be I think more, I'm leaning towards generalized epilepsy being more susceptible to sleep deprivation as compared to focal, though there is risk in both.
Okay. Back here.
Can you speak a little bit about sleep deprivation versus inconsistent sleep patterns? And I'm speaking of my college-age student who probably gets enough sleep, but it's out till 2, get up and go to class, then sleep all afternoon, then up, and then sleep again. So she may be getting 8 hours, but not the same 8 hour. Yeah, I think that's...
So you should go ahead. We just talked about it a little while ago.
Yeah. I think sleep deprivation, in my mind, when I talk about, so the sleep deprivation can be of two kinds. Typical sleep deprivation, which is more acute, meaning not sleeping enough hours, period, and that you were sleeping enough good hours or reasonable hours previous to that. So that's acute sleep deprivation. Chronic sleep deprivation model is in which you have done that for many months and years at a stretch. And in chronic sleep deprivation model, if you compute somebody's total sleep hours in a 24-hour period, they may not be bad. So for example, if somebody slept for 5 hours in the night and slept 2 hours here and there during the day, if you amount the hours, it's 7 hours of sleep, and they might be doing that for years at a stretch. So I don't know if, I think it is important, but chronic sleep deprivation probably doesn't have the same weightage in kind of increasing your risk for having breakthrough seizures. But I think acute sleep deprivation, which is probably defined as less than 4 hours of sleep or 3 hours of sleep on a night, I think you're more likely to have more breakthrough seizures because of that.
I think it's also an individual thing. Everybody just responds to sleep deprivation differently, whether it's acute or chronic. So it doesn't mean that every individual with epilepsy who is up late for an exam is going to have a seizure the next day. On the other hand, there are some individuals who are very sensitive, and if their sleep is off by a couple of hours, they have a seizure the next day. So the challenge is being able to predict something in a very generalized sort of fashion when things can be highly individualized. I think the question of a high school student, a college student, young adults, or even older adults who work jobs that incur a lot of chronic sleep deprivation. I mean, these are all very real issues, and I think, the more sleep you can get, the better sleep you can get, the better it is for epilepsy in general, is how we like to think about it. Now, how to enforce that practically in everybody, that's another matter entirely.
Okay. I think we are going to have to wrap it up. Unfortunately, I know a couple of people had their hands up. Hopefully, if you want to stay outside the hallway afterwards briefly, you can approach them to ask those remaining questions. But again, I want to thank you so much for sharing your time and expertise today, and thank you for sharing as well.
Good work.